Hi, everyone. Thank you so much for joining us today. I am thrilled to introduce today's speaker for this fantastic webinar. Jonathan Stewart is a Senior Director of Risk Management and Patient Safety at Beta Healthcare Group, where he serves as a consultant to hospitals, healthcare facilities, and medical groups. His current professional focus includes helping healthcare organizations operationalize communication and resolution programs, particularly the investigation and analysis of patient harm events. Thank you so much for joining us today, Jonathan, and sharing your valuable knowledge with our community.
Well, thank you, Nicole. I am privileged to be a part of this CRP community. I'm grateful to my mentors, and I thank all of you for your interest in today's topic. Though I have to confess, I don't know a whole lot about marketing, but I do know that you have to have a scintillating title to get people to come to your webinar. So I hope you'll forgive the bait and switch, but I wasn't sure anyone would tune in to hear my real title, Barriers to and Facilitators of Successful CRP Implementation and Application, which is also incidentally kind of the working title of my master's thesis. So I'm not sharing slides in a separate window, but if you just hover your cursor over me and maybe in the little three dots and pin me to your second screen or use speaker view, you should be able to see my slides and me together in the same window. No conflicts of interest. You know, I work for Beta, which is a promoter of CRP, as Beta Heart. I'm not expecting to say anything controversial, but if I do, any opinions expressed are my own, not necessarily those of my employer. And since I know we have some lawyers here, I also disclaim any warranty, express or implied, that we can actually achieve these objectives in a 1-hour webinar. Individual results may vary, but we'll try. So in our brief time together, I want to say a bit about how to define success and failure in the context of CRP, and then look specifically at the barriers and facilitators that we have found as they relate to the implementation and the application of CRPs. And then hopefully we'll have time to get your reactions and take your questions. Along the way, if I say anything that is unclear or that you disagree with, I want you to challenge me. I expect you to challenge me. And so I'm gonna make a point of saving time for that. All right, so let's start with just a few preliminary remarks. As you all know, we trace the origins of CRP to the Lexington VA Medical Center in the late 90s, and then University of Michigan Health System. There were just a few early adopters, but the number of organizations committing to, or at least claiming to be implementing CRP began surging around 2016 after the publication of the Candor Toolkit by ARC. So I was pretty excited when I made this graph, and then I started thinking about other innovations in US healthcare that probably had similar trajectories in their first few years. High reliability immediately came to mind. And of course, we know how that's turned out. It's no longer being marketed as a achievable state, but more like a lifelong journey. And we don't want CRP to go that way, but I'm encouraged that it won't, because the CRP movement is different in some very important ways. An obvious one is that unlike high reliability theory, which was conceived by a group of academics at UC Berkeley in response to the work of another academic, Charles Perrow, CRP, in contrast, was developed by practitioners in response to very pressing practical and ethical needs. And unlike high reliability theory, which is often peddled by consultants with MBAs, the CRP movement is being advanced by actual stakeholders, leaders within health systems and the medical, nursing, and legal professions, and by professional liability insurers, all of whom have a very real stake in the outcomes. So I think that's an important difference. But moving beyond just counting the number of organizations who say they want to do CRP, we have to really talk about the implementation and the application to individual cases. So that's what we're here to talk about today. Now, Tom Gallagher and others take the position, and I agree, that if CRPs aren't producing the outcomes we want, but we're not fully implementing and consistently applying the programs, it's hard to know whether the problem is with the program itself or with the incomplete implementation and spotty use. That's why I feel like this is exactly the right time in the history of the CRP movement to be having these kinds of conversations. And just like organizations ought to think of their CRP implementation in terms of a PDSA cycle, we in the CRP movement can think of it the same way. And I think if you look in the literature, it's pretty clear that as a movement, we're in the study phase right now, primarily. Of course, there's activity in other domains as well. So for purposes of our talk today about barriers and facilitators, I'm going to distinguish between implementation and application, because I think although they're closely related, they're two separate phenomena. So what do I mean by implementation and application? By implementation, I mean the creation or modification of the structures and processes that produce the outcomes that we're trying to achieve. I'm talking about policies and procedures, the tangible things, but also intangibles like relationships with stakeholders and influencers, and preparing key individuals to respond when events happen. I would analogize this to having a planned and adequately resourced code blue response, right? Facilities don't know when or where there's going to be a medical emergency, but they know with statistical certainty that it's going to happen. And so they invest in staff training, in equipment, in developing protocols, and even developing a quality review process because they know it's going to happen over and over. Well, likewise, healthcare organizations know, or should know, that there will be errors. There will be patients who experience unexpected outcomes that are disappointing. And so prudent organizations are prepared by having a comprehensive, systematic, and principled process in place. And so this is what people mean, I think, when they talk about hardwiring a process. Now, this button is literally hardwired. You push it and it sends a signal somewhere. I haven't seen anything this literal in CRP yet, but we'll keep using it as a metaphor. By application, I'm talking about the organization's response to particular events involving specific people, patients, and families. And just like with a code blue response, the application of CRP to a particular situation is a fundamentally human activity. It depends almost entirely on human volition, preparedness, technical and non-technical skills, and most importantly, adaptive capacity to be successful. I would argue that you cannot, by definition, hardwire human activity. If you could, you should use a robot or a computer because they're more reliable than humans. But they don't have, computers and robots don't have heart. They don't have will and volition, and they don't have the ability to adapt to overcome obstacles that humans have. So an organization guided by principles can, in theory, and in fact, I think we've seen this at Beta, in theory, an organization that has not yet fully implemented the structures and processes can, when they really desire to, and with some technical support, they can actually muster a CRP-worthy response to a particular patient or family that's been injured. It's possible, we've seen it happen, but it's very hard to do without the structures and processes in place. And it's even harder to reproduce more than once. But that's why I distinguish between the two with a significant area of overlap. We've seen that an organization may also have all of the structures and processes in place, but for some reason not apply CRP to a particular situation. And that's one of the things that we're going to try to explore a little bit today, or at least scratch the surface of. Okay, so that concludes my preliminary remarks. Let's jump into the first sticky question, distinguishing between success and failure in the context of CRP. It could probably go without saying, but I'll say systems don't produce good or bad outcomes. They just produce outcomes. And there's a certain amount of variability within a given range. It is the stakeholders that assign meanings to those outcomes. And actually where the line is drawn between good outcomes and bad, or success and failure, is sometimes contested by different stakeholders. So, if a patient who believes they have been injured by substandard care hires an attorney to represent them in their dealings with a health system, is that a failure of CRP? If the patient makes a written claim for compensation, does that mean that CRP has failed? If they file a lawsuit, does that mean there's been a failure of CRP? Well, I'm going to argue not necessarily, but I'll show you my logic here, and you can draw your own conclusions. I think one of the strengths of the CRP movements is that it is principled, not consequentialist. In other words, the process matters as much and sometimes more than the outcomes. Some have argued, quite strenuously actually, that the reason to do disclosure and apology is that it saves money on defense costs and indemnity payments. But that's not why we're doing this. And the problem with that consequentialist logic is that it can just as easily be used to justify telling patients or families half-truths, just enough to make the patient or family think that you're being honest with them or on their side, but not enough that they actually understand how serious the breach in the standard of care was. That sort of unethical practice could be justified by consequentialism, and that's why we are not taking that approach. Another issue is that the outcome, at least with respect to whether a patient brings a lawsuit, is really beyond the control of a health system. There's just too many covariates. Does the patient or family, do they have a prior experience where they have no trust of health systems or of physicians? Is there a lawyer activist in the family or a family friend who sort of incites litigation? There's things beyond our control within health systems, and we all know from process improvement school that when you can control the outcome, that's what you measure and that's what you judge yourself by. But if there's too many variables that are beyond your control and you can't control the outcome, then you measure what you can control, which is the processes that are within your span of control. And so for this reason, both the principles and the practicalities, it seems that the implied working definition of success in CRPs seems to be fidelity to the plan, integrity of process. And, incidentally, I spoke to a friend who's a clinical bioethicist, and I asked her, how do you judge success in an ethics consult? Because very often, one party or the other doesn't get what they want. In fact, sometimes nobody gets what they want. So how do you measure success? And this was actually her approach as well: fidelity to the process, integrity of process. So for our purposes today, I think that's the definition that I'm going to go with. So now let's get into the meat of what we're here to talk about today, which is barriers to and facilitators of success. And again, I said this is sort of a bifurcated analysis: implementation and application. So starting now with the implementation, the building of the structures and processes. So I undertook sort of a meta-analysis, light, a literature review, just to be humble, and I sort of semi-arbitrarily picked 2010 as the starting point. Lucian Leap's paper had been out for a few years by then, and that's when the ARC grant projects were starting. And I looked to see what there was in the literature about outcomes and lessons learned from attempts to implement CRPs around the country. I only looked at US-based undertakings. There's been work, as many of you know, in Canada, Australia, New Zealand, even something in the UK and perhaps in non-English speaking countries, but I'm limiting the analysis to the US. What I found was some recurring themes, and I've sort of coded them and divided them just for the convenience of discussion into three families of failure modes. So the first is what I'm going to call principle-related failure modes, and you can see them here. Some of you on the call, of course, were the authors of these papers, and so this will be quite familiar to you. And then there's what I might call prioritization-related failure modes. And of course, we understand competing priorities and disruptions include things like mergers and acquisitions, which health systems are seeing another wave of those now. But other things like construction or remodeling projects, new electronic health record implementations, pandemics. Perhaps we'll have some time to talk toward the end about how the COVID-19 year affected uptake and application of CRP. And then a whole lot of sort of practical barriers to implementing CRP. And I put at the top of the list insufficient personnel. That appeared in pretty much everybody's assessment. The reality is that this work, it takes more time and it takes more effort than standard care. And organizations that were successful often added additional staff, like in the form of like a project manager or coordinator. Turnover and loss of key individuals or champions within the organization was also frequently cited as a contributor to success, or rather to failure, and a general lack of awareness among clinicians about the aims and the processes of the CRP. And this is unsurprising because, as a former hospital risk manager, I can tell you, and most of you know, that organizations' responses to patient harm events have traditionally been shrouded in secrecy. And any individual clinician, they might only hear of one or two serious adverse events per year, sometimes less, and they never know what happened afterwards, unless perhaps they were deposed or something. So the feedback to clinicians and people on the front lines about what happens after a harm event is long delayed or frequently absent altogether. And so it should be unsurprising that frontline staff don't necessarily know what to do or expect when one of these events occurs. But I really wanted to talk because that's been pretty well spelled out in the literature so far. I only found about half a dozen papers on this particular topic, but I've no doubt that there's more out there and more on the way. But what I'm really interested in, and what the focus of my graduate research is going to be, is on the barriers to and facilitators of success with applying a CRP, communication resolution program, to individual events. And there's a lot of interesting content that's come out here. So, much of it is in the existing literature. I'm also drawing from my own professional experience and conversations with many others, and good old-fashioned sort of prospective imagination, right? Which is the way a failure mode and effects analysis works. So, I haven't yet collected data or done data analysis with the beta heart cases, so I'm not able to speak to those. But I think there's enough content that's already out there and well understood that we can put it together for a pretty complete failure modes and effect analysis. So the way I'm going to be presenting this is through what's known as a bow tie diagram. Some of you may have seen this. They've been around for decades and are commonly used in process industries, but for whatever reason, I don't see them in healthcare, at least not on the West Coast. So even though I haven't done the data collection and analysis yet, I do have some hypotheses about the barriers and facilitators that I'm going to find. And it has to do with complexity. The responses of organizations, of patients and families to serious, unexpected clinical outcomes are complex, not just complicated, but they are complex. And this has several important implications that are hard to put in an infographic. So one feature we know of complex systems is that outputs are not necessarily proportionate to inputs. So after a clinical, an adverse clinical outcome, right, a adverse event or just a bad outcome, especially if there were defects in care somewhere along the way, we know from experience that sometimes a seemingly trivial thing can produce disproportionate amounts of anger and mistrust in a patient or family. So for example, say there's been an unplanned return to surgery. Maybe it was a unavoidable, even a foreseeable complication of the procedure. And then the next day, but it's extremely stressful, right? And the patient ends up in the ICU. This is a hypothetical. And the next day, the patient gets their Tylenol half an hour late, and the family goes into a rage. It's disproportionate, right? It's not in proportion, but it shouldn't be expected to be proportionate because human interactions are complex. Likewise, sometimes just small, seemingly insignificant empathic gestures can diffuse righteous and justifiable fury. Just a small show of humanity and compassion is all it needs to diffuse a highly charged situation. So outputs are not proportionate to inputs, an important feature of complex systems. Another is that the processes are non-linear. And I think this is one of our important learnings in the last couple of years. An organization's response to harm events, it just doesn't happen the same way each time because each situation differs in important ways, right? The people involved are different. The clinical facts are different. The situation is different. The underlying illness and the prognosis are different. And so, like so much in healthcare, this is where the human contribution to the process, our ability to anticipate and adapt, makes all the difference. So I have an example here somewhere. Yeah, so the first few steps of a good CRP response by the organization, just recognizing that a harm event occurred and activating the organizational response. I personally have tried to create flowcharts depicting what this process should look like for detecting, recognizing, and communicating adverse events to risk management or the house supervisor, whomever. And I can do it, and I can make flowcharts that look pretty good, and they work most of the time, but not all of the time, right? Because as I said, the facts are different, and importantly, how the information comes to the attention of personnel is variable, and so it's probably more intellectually honest to depict it as a cloud, right, or a black box with inputs and outputs without trying to go into too much detail about how the inner workings go, because they are dynamic, they change, and they're nonlinear. I know I've gone off into deep water, and I'm probably going to regret this, but I'm looking forward to. I'm trying to fertilize the ground for a good discussion here. All right, with those things in mind, let's look at likely failure modes and likely consequences for different aspects of CRP application. Just as a reminder, the logic of FMEA is to look at the steps in the process. Often there are parallel processes that might happen, all of which could lead to the same outcomes, but looking at steps in the process and forecasting all the things that could go wrong, the probabilities of failure, and what would happen if those failure modes occur. Now, I'm not trying to present to you a complete list today, but rather I wanted to focus on those failure modes that seem most common or otherwise worthy of discussion. So I've broken it out into sort of the major functions of a communication and resolution program. And the first is the activation or initial management. So I'm not going to read the slide. Instead, I'm looking in the chat box. Okay, looks like we're okay. So, so the way this works in a bow tie diagram, as you can see, the threats are on the left, which are the failure modes identified, and potential consequences are on the right. Again, nonlinear and not necessarily proportionate. Here, I'll say a few things about premature determination of care. Care is being appropriate. So if one of the steps in an organization's process after a harm event is to immediately screen out events that after a sort of a superficial check to see if care was appropriate, that organization may be missing opportunities to muster a CRP response when they should have. I'll be a little bit more specific. So, in an organization where sort of step one or step two after an adverse event comes to their attention is to just have an informal conversation with the unit manager or with the chief of the service and say, this happened, is this a normal complication? Or, was care, appropriate in this case? And the manager or the service chief just sort of informally gives an opinion. Yeah, I think care was probably appropriate here. I might have done it differently, but yeah, this is one of those things. And then the analysis stops, right? That organization is probably doing a disservice to patients and families because we know from experience that sometimes you don't know the whole story until you actually get up and do the legwork of interviewing the people who were involved. You can't get the whole story from just reading the medical record and reading the chart notes, right? Or the incident report from one person, for example. So that's what I'm talking about there. And then the point below it, premature determination that harm is below some minimum threshold. So, at Beta, we've talked a lot about, what is a heart response? What is something that should trigger a CRP-like response? And ultimately, I think we've come to the understanding that there is no bright line threshold for something that warrants compassionate and timely communication, caregiver support, and so forth, because this is a principled approach to the problem of patient harm. And so it scales up and down. It's completely scalable. Now, it is certainly true that sometimes service recovery, the entire CRP package in miniature can be accomplished at the bedside. Think about a phlebotomist who has to stick a child 2 or 3 times in order to get a blood specimen. Service recovery can be accomplished right there by the phlebotomist acknowledging the harm and apologizing, perhaps offering to get somebody else to do the work, going out of their way to get, a cartoon Band-Aid if that's what the child wants. So it's the same principles. It's just scaled down to the micro level at the bedside. But those same principles also scale up to major catastrophic patient harm events. So that's why I say I personally think it's problematic to have a artificial threshold of harm severity below which the organization will not respond in accordance with the principles of CRP. And perhaps I'm setting up a straw man. Maybe no organization really does that. But I identify it as a potential failure mode. Let's look at another step in the process, inadequate investigation or analysis. So this is a major function of CRP, and there are several ways in which it its success can be threatened. I think a big one is delayed start right? From either delayed recognition that something has happened or delayed communication within the organization about it. And we know from experience that this is more challenging in ambulatory settings where the problems are often related to delay in diagnosis or consultation management. Inadequate resources, I mentioned earlier, doing this right requires legwork. It requires people to be able to make phone calls and have those hard but necessary conversations. And it's not just the risk manager, right? It's people in all different departments that need to be recruited. And so inadequate resources in terms of personnel is a big one that was identified in the literature. Another issue is the delayed start while waiting for an RCA team to be constituted and have their first meeting. So this is something that's been identified not just in the CRP literature, but in the patient safety literature generally. We know quite well that memories fade, memories become confused or contaminated as witnesses to an event talk to each other or they ruminate about their own role in the event. That's why we're just, at Beta, we think it's very important that investigative interviews be conducted promptly and skillfully. And that's why we teach the cognitive interviewing suite of skills that we learned from Dr. Ed Geiselman. But, there's other problems with delaying the start of the investigation. Evidence is lost, it's thrown away, right? Medical devices are reset, they're returned into use. Consumables, that blood tubing, that IV tubing, that medication vial, they all go out in the trash or the biohazard bag unless somebody shows up almost right away to save, secure, and sequester that physical evidence. And so that's an important part of our teaching at Beta as well. When I say failure to interview key witnesses, I'm largely talking about the patients and families. It's been said before, and I think it bears repeating, that patients and families are often the eyewitnesses, the only eyewitnesses to the entirety of the event that happened to them, right? This has been somewhat challenging during the time of COVID when patients were alone in the hospital and didn't have somebody, sitting by their bedside able to, see what was happening. But it is certainly the case that patients and occasionally families have information that nobody else has, and so I think one of the important failure modes is interviewing key witnesses. And then there's one particular topic I want to pull out all by itself here. In CRP, investigation analysis is a means to an end. At some point, the organization has to turn the corner and turn its focus from figuring out what happened to putting its attention on, okay, now what do we do next? And in particular, what do we do for this patient or family who has experienced harm? So one potential failure mode is that the organization fixates on their RCA and how to communicate the findings or what they can share and what they have to keep secret. And they don't appreciate that the patient or the family is not looking backward right now. They're looking forward at the crisis that they still have in front of them, especially if somebody has died or experienced a new and severe disability. And so, maybe what the family or the patient wants is grief support, wage replacement, housing, childcare. How are we going to solve these immediate problems right now? And so one potential failure mode is that the organization, again, gets stuck on what happened and fails to appreciate that it's the patient or the family's agenda that may be quite different. And so being sensitive to that. Next, we have failures of communication. Right? So communication is central to success in CRP. And there's, we know from the literature and from experience and from our imagination, many ways in which it can go wrong. It can not happen at all. It can be delayed. We've heard it said that every hour that goes by without a medical injury being acknowledged is an additional harm. But there's a lot of nuance here. Again, patients and families, after trust has been breached, trust with their clinicians, trust with the health system has been breached, they can be very sensitive to just minor slights, like not calling when they were told that they were going to receive a call. And so the sensitive and effective communicators that we rely on for success have to be well tuned in to the emotional state of the patients and families. And if there's a misstep, they have to be able to recognize it and recover. And that's something that by identifying highly skilled and effective communicators, those are the folks we're trying to move to the front of the communication team. Certainly, problems can occur if incorrect information is shared early on, or there's speculation about causation that can't be walked back later. Somebody in the past raised the issue of promises of transparency to the patient or family that end up not meeting the patient or family's expectations. I think this is, in a way, in fact, I think this was briefly touched on in one of the collaborative webinars maybe a couple months ago. I think this is maybe a frontier for research and exploration, exactly what we mean by transparency, because we know what we mean, but perhaps patients or families, if they're told, we're going to be completely honest and transparent with you, but then they want to know, well, has the surgeon ever been involved in an event like this before? And suddenly the organization said, well, we're going to be honest and transparent, but not about that, right? It becomes harder to bridge that trust gap with the patient or family. So this presents an interesting problem that requires a lot of wisdom, and I'm not sure the answer. And then, at the bottom I put the tone of interaction changes as the sort of the case file is handed off to claims or to to the attorney. And I draw on my own work experience at the U.S. Veterans Health Administration for this. One of the things that I'm quite proud of in having worked for the VA is its commitment to transparency and doing right by veterans that have been accidentally harmed. And as a risk manager and patient safety officer, I was quite proud of our ability and to do that because the organization was supportive. However, if or when a veteran files a tort claim, the matter gets handed off to the U.S. Department of Justice, and they have a very different philosophy. They have an extremely different philosophy, and so that trust that was built and carefully cultivated could be lost. And then failure to pursue early resolution. And you can see that there's reasons for that, much of which are well documented in the literature and easily understood from our own experience. I'll give you just a moment. So let me pause here and see what questions we might have.
Jonathan, this is Tom Gallagher. It's just a wonderful presentation, so careful and thoughtful and cogently presented. I agree with you that one of the real challenges that you're hitting at is how do we hardwire complex, non-linear processes where humans are really central to the entire undertaking. But I wondered if you can muse at least either now or a little bit later on, are there parts of these failure modes that would be particularly amenable to automation or technology or something where we're providing support for humans to do the parts that they really do well more effectively.
Jonathan, you're muted.
Thank you. And thank you for that interesting question. I'm going to park that for a few minutes so I can return to it. But I love that topic. There's actually a term for it, I learned. It's haba maba. It's distinguishing between what humans are better at and machines are better at. So let's come back to that momentarily. Thank you. So for organizations that are working on implementing and applying communication and resolution programs and using a PDSA cycle as they should, there's another tool that I might suggest if you're at a health system, and that's the Aggregate Rca. And this is actually something else that I learned from the Veterans Health Administration. This was developed there a number of years ago. You can read the article, but the idea is taking similar events and batching them together to study them. And if you're interested, we can talk more about that as well. So let me take just a couple of minutes to review and sort of wrap up my prepared comments. I think some organizations participating in Beta Heart, at least, have successfully applied CRPs to challenging cases, and we can learn from their successes. They're justifiably proud and have something to teach. And so I'm going to maybe highlight some of the principles that have come from successes by way of review. So speaking of principles, we think that it's clear from the literature and from our practical experience that part of the recipe for success includes agreement among key stakeholders on why we have a communication and resolution program, and an understanding that that with an endeavor like CRP, the process is as important as the outcome in any individual case, and sometimes it is more important than the outcome, which is beyond the organization's control. Another is that it is an organizational commitment, a holistic commitment, not a risk management program. And considerable amount has been written about that, and we can say more. We've talked about the importance of preparedness and having adequate resources, and that seems to be a common theme, both in the literature and from our own experience. That certainly makes success more likely, although it doesn't guarantee it, because the secret sauce is this, whether the event happens in a hospital or a clinic or in long-term care, whether it's an error of commission during a procedure or an error of omission in an ambulatory setting, whether it comes in as an incident report directed to the risk manager, or it comes in as a grievance directed to patient experience. A adapting and resilient organization will channel the information to the right places and will recognize that it needs to activate a response. That's the sort of thing I'm talking about when I say this is a fundamentally and inextricably human endeavor. It just can't hardwire something that requires human understanding of the goals and the principles and human vigilance to watch out and spot the issues, even if they're not presented as something that would traditionally trigger a CRP response. And so continuing on that thought, I think that CRP, communication resolution programs, are better analogized to a bicycle than a ski lift, by which I mean it's not something that can just be built and then powered and activated and then it starts running on its own. It requires continuous human inputs, more like a bicycle, right, in order to move forward and to stay upright. All right, so maybe that's a tortured analogy, but I've made the pilgrimage to Virginia Mason. I've led ISO 9000 projects. I have my Lean Six Sigma green belt. I know that it is possible and it is desirable to develop routines and standard work. And yet the secret sauce is the human adaptive capacity that requires, among other things, the bandwidth to do this work. So, if the risk manager, patient relations, other key individuals are just putting out fires and running from meeting to meeting every day, or medical staff leadership is not bought in and willing to do the extra work that it might take, then it's a barrier to the success of the program. And it's a barrier that simply having policies and procedures and protocols cannot in itself overcome. So let me stop there, and we'll begin our conversation, questions, abuse, whatever you have for me.
While people gather their thoughts, we had an initial question in the chat box from Lane Steffen, and he asked, what's a reasonable time frame for when determination of appropriate versus inappropriate care occurred? And what advice do you have for keeping patients and families engaged when the review process goes on for months?
Thank you for those questions. So to the first one, how long does it take? I'll share with you some wisdom that I learned in law school, because it's what lawyers call a depender. It depends, right? It depends on the particular facts of the case. But there's options, so sometimes the internal analysis can be quite speedy if you have the subject matter experts on hand and they're willing and able to review the investigation findings and make a determination. It can be quite quick. Other times, in more complex situations where causation is unclear, and it's not clear that a defect in care actually caused harm, or even that there was a defect in care at all, given the circumstances, or when there's a question as to sort of the magnitude of harm, how much is attributable to the inappropriate care and how much is attributable to the patient's underlying disease process. Sometimes this might have to go out for external review. At Beta, we think it's probably not necessary to wait for litigation in order to hire a medical expert. There are situations in which it's in everybody's interest to hire that medical expert for an opinion without waiting for a lawsuit to be filed. So to your other question, how do you keep patients and families engaged? My thought, and there's a lot of expertise, in the audience here, and so I'm certainly inviting others' thoughts. But I think investments up front in establishing rapport with the patient or family and setting realistic expectations will pay dividends as the weeks drag on. In my limited experience as a hospital-based risk manager, these processes typically do take longer than the patient or family imagines that they will. And it can be hard to explain just why that is. Sometimes, if an autopsy is required, right, that can be a 6-week, 2-month or longer delay in getting answers to some questions that can't be answered in any other way. So an upfront investment in setting realistic expectations and checking in periodically will pay dividends, I think.
Thank you. We have another question from Kay, a question and a comment. She refers to the frequent references to inadequate staff, beg for more analysis, and wants to know, how does an organization staff appropriately?
Yeah, let's research that. In fact, if you can secure grant funding, I'll research it. I think that's an empirical question that has not been fully explored. And I'm really curious about that as well. So I can't give you a better answer than that, except when CRP is not applied or fully implemented, researchers have found that that is one of the contributing factors. But how much is enough, I think is not fully known.
Let's Okay, some more comments. Dr. Gallagher would like to hear more about where technology can help, if you're ready to answer that question.
That's something I'll have to give more thought to. We know that RL Datix, we've been hearing from our members, has been making some updates to actually incorporate some key elements into their product for their users. That's exciting. I don't know the specifics of that, however, but it seems promising in principle. I think anything that facilitates communication, speedy communication among people who need to be aware of developments is probably a good thing. So we know that events that happen nights, holidays, weekends, when administrative and managerial types are less likely to be in a facility, frequently result in a delayed response. And this can be problematic, in a hospital where, if the patient is discharged on Monday or Tuesday before anybody has a chance to, even see the alert and follow up, this can be a missed opportunity. So I think there's probably technology-based opportunities to enhance critical communication among stakeholders as well.
Let's see, we have a response from Doug about communicating with patients and family on an ongoing basis. And he says to touch base, I just scrolled, to touch base at least once a week and put it in a chart. Don't let them feel abandoned. At some point, interview the family as part of the review process and make sure that the family feels heard. So thank you, Doug, for sharing that advice. We have another question. Is there any concern that CRP response could prompt patients and families to an attorney or give them the impression that we think there is a claim?
So that's a perennial topic of conversation. It even goes back to the early days of when the programs were called disclosure and apology programs. So the way I see it, and I'll speak in my personal capacity, I see that as sort of although it's a commonly asked question, I think it's a false choice. I think the real choice is whether to be honest or to conceal the truth about clinical outcomes and what happened to patients. And when I frame it that way, it seems like a pretty easy decision to make. The questions that sometimes used to come up were, they're related to peer review privilege. And if we tell the patient or the family this, we're going to be giving up peer review privilege. And the answer was always, what is it that you want to conceal from the patient? Why are you so worried about your ability to hide the truth from the patient or family? So it's why CRP is said to be a principled approach, and so that's sort of my take on things. So is it possible to let patients or families just believe that a bad clinical outcome was just one of those things, bad luck, an act of God, when in fact it was the result of inappropriate care? Yes, that has been done in a bygone era. But organizations who believe in the precepts of CRP choose a different path. I hope that's responsive to your question.
And Steve has a question. How can patients and families play a role in helping organizations develop and improve their implementation of CRP?
I'd like to hear your thoughts, Steve. That's something of great interest to me as well. I think there's a big opportunity there. We want this very important work to be patient and family centered, and yet, we hold so many of the cards. So, how to accomplish that?
Yeah, if I could just tie in real quick. I think it is a good question, and And I think part of it is we just need to get over that kind of hesitancy to lay all the cards on the table, because there's a lot of things with organizations that they may be a bit afraid to open up as much as they could be. So that's kind of why I asked the question. I mean, I think it's good, but it's a tough question, I think.
Mm-hmm. One of the things that we're doing as part of the Beta Heart work is we're encouraging organizations to involve patients and family representatives with process improvement action plans. So not necessarily the individual or the family that was harmed by an event, although they may be the very best person to be involved, but at minimum, anything that would place a burden on the patient or family as co-producers of their own health outcomes, check with patients and families to make sure that that's realistic and equitable.
Thanks.
Other questions?
We have a question from Austin. So are there any ways to measure the strength of a just culture in place and success of a CRP? And is there variation amongst different methodologies for looking at a just culture, such as Marx versus Reason versus Decker?
Well, I feel like we could probably have a really good conversation offline. This is a topic of great interest to me as well. So the short answer to the question about measurement is, it's very hard to get a direct measurement on the justice of a organizational culture. And in fact, I would say that, justice in culture is not a state. It's more of like a transient state. It's like being an ethical person. You are until suddenly there's a lapse, right? So it just depends, where you are on that snapshot in time when you're looking at an organization's just culture. But probably the best proxy measurement that I know of is the culture of safety survey. We use the SCORE survey, but there's others that ask specifically about whether people think that they would be unfairly blamed for system failures beyond their control, for example, or if they would be punished for just reporting that there was an adverse event. So that's probably a pretty good proxy measure. We think so. Now, in terms of the different approaches to just culture, I think that's a great conversation. Instead of trying to answer it here, I will suggest a series of 3 podcasts that I recently listened to from the Art of sort of the Safety of Work podcast. I can try to find a link here in a little bit, but these 2 really brainy PhD human factor scientists in Australia talk about the origins of just culture as a concept, from Reason to Marx and on to Sidney Dekker.
I think we have time for just one final question, and that's from Linda. How do patients help push for the patient to be included in the RCA? Patients, the result of the review, who haven't been asked any questions about what they saw and heard.
Yeah, I think this is an important topic for me. Some of you know that my wife and I used to serve on the PFAC of our community hospital because I really wanted to participate in meaningful change, and it's hard sometimes for organizations to develop a level of trust, right? They just don't know what's going to happen if you let a patient or family have a voice. And I think we're much better than we were in years past, and we're not as an industry, as a hospital industry. That's what I'm referring to, and we're not where we want to be yet. But that's not really an answer to your question. And particular events, if I were speaking to a individual who felt like they'd been harmed by the healthcare they received, I would encourage them to proactively reach out to their contact at the hospital, the patient safety manager, risk manager, patient relations, and let them know, I was a witness to this, and I want to share what I saw. and heard. I want to tell my story. And, and it probably doesn't hurt to be asked, hurt to ask to be included in the RCA team. But I'm not aware of organizations that are going that far yet.
Thank you so much, Jonathan. That brings us to the top of the hour. That was a truly fantastic presentation, and we thank you so much for your time, and we thank the community for joining us today.